All right. Thank you all so much for all of your talks today. They've been so informative, and we've had some really great feedback and some great questions. So some of them, there's kind of some general questions that perhaps anyone on the panel might be able to answer. Might someone be able to tell us a little bit about the mean age of first attempts? When do we start seeing suicidal behavior in individuals? And are there any subgroups of individuals? We had one specific question about transgender individuals that we might want to be monitoring as young adults or as teenagers. Anyone?
In terms of age group, suicidal behavior below the age of 14 is rare. It does happen. There's a small number in the age range of 10 to 14. It starts to increase from 15 onward. And there's a kind of a large cohort in the age range of young adult, 21 to 24, where you see an increase.
To the second part of that question, actually, I guess I'm not going to do that. In terms of transgender individuals, actually make up a large proportion of my practice, and they do have a higher risk for suicide as another potential, broadly speaking, risk factor. And then we might think that there might be very different underlying mechanisms or reasons for that than in some of the other diagnoses that we've talked about today, including borderline and bipolar disorder.
Great.
I can add to the pediatric question. So we actually get quite a few questions about when do you start administering the scale, when do you start doing the assessment. And I just want to mention one study that came out literally just came out. And it really looks at suicidal ideation in preschoolers and kindergartners. This is a very robust research program, and it really looks at continuity of not behavior, but suicidal ideation and how it's assessed. And so in terms of the frequency of behaviors, Barbara, I think, answered that question. There are a couple of really good articles to that effect, including Matt Knox and Ron Kessler's piece documenting the really low incidence. But in terms of the early signs, if you will, of suicidal phenomena, then we certainly have evidence that suicidal themes do begin emerging in very early childhood and unfortunately continue.
Thank you. Dr. Stanley, we had a question asking whether you could comment on safety planning for inpatients, especially during the high-risk period when a patient is about to be discharged to the community.
The only time that safety planning shouldn't be done with suicidal people is when they are in the midst of an emergency themselves. So if they need immediate rescue, like for example, crisis hotlines do safety planning with people. But if on the crisis hotline it seems like the crisis is not going to de-escalate, then you don't do a safety plan. I can say that safety plans are being done on inpatient units, in jails, in emergency departments, in an outpatient setting. So I think it's appropriate to do in all of those settings, and it's a good thing to give to people who come in for a suicidal crisis. Right now we have started testing out. We're just doing a small feasibility study looking at an inpatient group treatment for suicidal patients. That's like a 4-session thing. Each session is a standalone session. And one of those sessions is doing safety planning.
Terrific, terrific. Another theme that's really come up in the question is that is a theme that was across talks today about interpersonal triggers of suicide attempts. So that came up again and again in the discussion. And some of the audience had questions about what specifically can we be doing with clients to help them handle their potential interpersonal triggers. And related to that, a second question are interpersonal triggers more an issue of emotion regulation, distress tolerance, or something else altogether?
Well, I think in terms of what we can be doing, in thinking about how our patients view themselves and view other people, how they think about what other people are thinking. That was what I was thinking. On one of my slides, I talked about mentalization-based interventions, and this idea of helping them to better understand the perspective of others, how others might be interacting with them in ways that will then help them to kind of manage some of the negative affect that comes with those negative or perceived negative interpersonal experiences. So I think helping with kind of stability and sense of self and stability in terms of how they're viewing other people can really help. And for me, I see that a lot with the interpersonal effectiveness modules, as I said, but I also think mindfulness of being present. I think emotion regulation of helping with regulating negative affect in these interpersonal encounters will be very helpful. And always as a first line, the distress tolerance skills in terms of immediately being maybe distracting or removing from an interpersonal situation that could be really high, intense, and affect.
So the last half of that question is a really very important question about what causes what. And a lot of us who do research in this area are thinking about that, and we really don't have the answer. I mean, that's like the $50,000, $50 million question about, is it the emotion regulation that causes the interpersonal dysfunction or vice versa? We actually really don't know. The thing I will say about interpersonal triggers is, number one, for people who make suicide attempts, there is always a trigger that we can identify. And so for people with BPD, it's more on the interpersonal than the non-interpersonal. So in a certain way, I kind of don't make that much of that. But on the other hand, that trying to understand the interpersonal dysfunction is actually really complicated. So I'll give you an example. Eric Vertug, who is young investigator working with me, did an fMRI study where he looked at a rejection paradigm in the scanner. And what he found is that people who have borderline personality disorder take each rejection in the same kind of way, as though it's like, so a rejection in the context of a lot of acceptance is experienced as just as much rejection as rejection, as opposed to people who don't have borderline personality disorder, who they acknowledge the rejection, but it is only bad when it's in the context of a lot of rejection. And so, not to get deep into this study, but in other words, it's like, it's not something that is incredibly simple. It's a complex phenomenon to understand what the interpersonal dysfunction is in borderline personality disorder and what the underlying neurobiology of it is.
Great. Another set of questions really focus on the idea of whether, we've been talking a lot today about predicting suicidality, whether we're very poor at it right now, but are there always triggers of suicidality, or is there actually suicide attempts with absolutely no triggers, with absolutely no predictors? What does the panel think of that first premise?
A cough drop. But I think that in general...
Can you speak up? Speak up.
Yeah. our clients would probably come in and report many different experiences with suicide behaviors. And to say unilaterally that it never happened, I don't know. I think that we try to avoid unilateral statements. But again, when you break down very carefully, like in behavioral chain analyses, these suicide attempts, often we can help increase understanding and insight into potentially some of the things that might contribute to a suicide attempt. And I'd say probably more often than not, there is something, even if it's something that is might be seen as relatively small, but that there can be something that happened prior to or leading up to a suicide attempt. Maybe others would disagree on the panel, but.
I just have, one comment as a family member on that, and that is that oftentimes when we would experience episodes, attempts as a family, what would happen is, you go into see the clinician, and they say, well, what prompted this? And you say, nothing. There was nothing at all prompted it. And we couldn't pin down a specific event. Oh,
Yeah, that makes sense.
sorry, there were oftentimes, is that good? That we couldn't pin down a specific event that preceded the attempt. So, but there always was. It just took time to find out what it was. In our case, with our son, there often was a trigger, there was an event, there was a thought process that he eventually over time could identify, but not in the short term, perhaps not in that first couple of sessions with the clinician after the attempt.
So one thing I would say about triggers is the trigger is just the last thing that happens prior to the attempt, and that there are many other things that that kind of lead up to that attempt, and so you could, and the reason I guess I was saying that we shouldn't put that much stock in individual triggers is because a lot of times you can have the same trigger and nothing will happen. And so it just is kind of like that cascade of things that then you identify that, okay, that was what happened just before, and so we call it the trigger, but it's like a whole bunch of things that are the triggering events.
If I may
You're good.
add? Okay. To me, it's also important to reframe that question in a couple of different ways. One instance and one scenario when that question comes up is, could I have foreseen this happening? And as a clinician, as a parent, the desire to predict usually is associated with, could I have foreseen? And the answer to that question most of the time, a lot of the time, is no. And the other way to look at the question, is there an explanation? Is there a cause? And this is, the other speakers have already addressed, and there are explanations. This is explainable phenomenon.
So it also sounds like from the talks today that you might say that when we initially ask the questions, there seems like they don't have suicidal ideation beforehand or before the attempt, or they don't identify the triggers. But as we ask more structured clinical interviews of suicide risk, that we might be able to ascertain more clarity in that thought process, in the nuances of what is really leading up to it, and that maybe something interrupted it, and so they deny that it's a suicide attempt, but it really might be. So there's both an assessment issue and then also a clinical issue to that question. Would you guys agree? Yeah. Okay. So another question really focused on how, with regards to assessment of a suicide attempt and framing and understanding of it, how often do you include family in both the knowledge and assessment of suicidal ideation for adults, not just adolescents? You're good. It just takes a second to warm up.
That's a really good question. So and it's complicated because because when you're dealing with an adult, as your patient, it depends on what the patient's wishes and desires are. If the patient doesn't want the family included, they're not included. They can't be included. But one of the things that in my work, there are often individuals who are adults, but who are really kind of cared for still by their parents. And so one of the things that I make clear to the family members and the patient is that it is fine for family members to communicate anything they want to me, either by phone or by email. Even if my patient doesn't want me to talk with them, I can receive information, and I'm happy to receive information. And my patients know that I would never say to a family member, you cannot tell me that, this happened over the weekend. So that becomes a way to actually learn about the important clinical information that the patient may not be sharing with me. If the patient is willing and wants this, what I often will do is include the family member in the development and sharing of the safety plan with them. Especially because they are on, usually if it's a spouse, they're on the safety plan. And so it's important to know, for the patient to know, are you comfortable talking with this person and letting the person know they're on your safety plan? And so it's a good way to kind of bring the person in.
Thank you. Anyone else? All right, another question focuses on how some individuals, when they are in a crisis moment, maybe before a suicide attempt or when they're planning, they might have their memory processes impaired, or they report that they weren't able to remember details of it, or they also report they weren't able to remember coping skills in the moment. What might you recommend for clients who report that, both for assessment and planning intervention?
Well, again, I think that there have been abnormalities shown in attempters in the hippocampus, which is involved in memory processes. And while we may not completely understand how memory processes get disrupted, it is possible that there is some retrieval difficulties in those moments. And then I think the first thing that comes to mind, again, when we're thinking about different strategies, is some distress tolerance to just wait for a little bit, to have them have crisis survival strategies already planned out, maybe during sort of a crisis plan that can be part of it as well, this is what you try first when you can't remember anything else. Because then that buys time for the emotional responding in the brain to start to subside, for some of these other brain circuitry to come back sort of online to enable them to retrieve what they know to do. Then over time, hopefully it becomes more routine and more habit so that there's less difficulty in retrieving what we're supposed to do. But maybe earlier on in treatment too, there can be slightly more difficulties as we're learning new techniques that have been newly sort of formed as memories, as it were. So,
In my experience,
Just give it
people don't forget what happened prior to a suicide attempt unless they were under the influence. And then, of course, they're not going to remember. But when you sit down with somebody and the experience of nothing happened or I don't remember nothing, one of the things that I say is basically kind of like humor me. Let's just try to. We don't have to say this led to that, led to that. We'll just do a chronology of events, a timeline. And by doing a timeline, you're not saying this led to this, but you're getting the timeline. And then you can see what is happening along the timeline. So it's a very different kind of it's a figure ground kind of thing, and it makes it easier for people to trace backwards. But people do remember unless they're intoxicated.
All right. Well, thank you very much, speakers panel. We're going to wrap it up just a little bit late today, but we greatly appreciate all of your comments and your suggestions. I also want to thank, down in front today, there have been two individuals who've been working very hard, Sandra Lee and Anita Benjamin, who have been translating, sign language translators all day. They have had a very long day, and I just want to give them a hand. Thank you. Thank you so much.